The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Morning, George. It's Tuesday morning again, and we have a phenomenal guest today who's going to talk about all things in independent practice in Georgia.
Yeah, so we have Dr. Michelle Cook. Her title for today, the discussion is going to be about lessons learned from the retail failure of primary care and why. We're going to talk a little bit about independent practice, direct primary care. We're just going to mix it all up. So, Doc, we usually start with our pediatric friends and ask them, why did you become a pediatrician? But you're family medicine. So why did you become a family medicine and why did you go into DPC?
The short answer, which is it's so hard. I'm a physician, I'm not a pediatrician, but I have taken care of children for most of my career. So I feel very adjacent to my peds family in that respect. Family medicine, I went into it really because as a med student, when I rotated through all the rotations, I could see a little bit of myself in everything. And so when you can't really choose, I think you become a family doc. Love the kids, love the adults, love the women's health. Not a big surgeon, but I like a lot of those outpatient procedures. Family medicine allowed me to keep all of that in my practice and really develop longitudinal relationships with my patients. So that was the biggest draw. I worked in what we would call the traditional insurance-based fee-for-service model for approximately 10 years. What I tell people, my mantra now is I love what I do, but I hated the way I was doing it. The loss of autonomy, not enough time with my patients, endless paperwork, just feeling like it was a trap all the time. And my healthcare system collapsed. I'm in Atlanta, large city, and one of the healthcare systems that was servicing South Metro Atlanta ended up closing 2 hospitals and multiple primary care clinics. And so that was a wake-up call to me. I say it was a terrible day for the community, but for my professional career, it was my ticket out. I've been looking at the direct primary care movement for a while and just never felt brave enough to jump. And then when that happened, it just showed me that this model is not working. I say it was not for lack of patients that we closed. It's because we had a business model that didn't support the community. So that the push and the bravery and the freedom from my non-compete to open my direct primary care practice, which is exactly what I did 6 months later. So direct primary care, I chose that because it allows me to be the family doctor I always wanted to be, have time with my patients, relationships with my patients, the freedom to have more time and visits to talk about the psychosocial issues that are impacting them. So it's opened up my world for medicine and has allowed me to practice the way I always wanted to be able to practice.
That's beautiful.
But why did your health system collapse?
So it's a large health system that services a good section of the metro Atlanta area. And the part of the health system where I work, so the whole system didn't close, but the section where I worked in Atlanta did close. They've been successful in citing all the reasons, but the major reason is that it wasn't financially stable. So we had a poor payer mix, if you will. A lot of the people in this community were Medicare, Medicaid, not a lot of commercial insurance, and many uninsured. The 2 hospitals that supported this region, one was a level 1 trauma center. So it was incredible to lose a level 1 trauma center in your city, but their emergency departments were so busy and serviced the most underinsured and uninsured patients in the community. So there's a lot of people coming in, getting care and services that was never compensated. So there was so much money going out and not money coming in that they eventually decided that it was unsustainable and closed the practices. The sad part about that is even though I was not a hospital-based doctor, the way today's healthcare system works is that primary care feeds the beast. They look at us as a loss. We work to feed the hospital. They depend on us for the referrals, for the mammograms, for the imaging, but they didn't really need us for not money makers, if you will. So when they closed the 2 hospitals, they closed all the supporting outpatient ambulatory facilities with it.
So where did all those people go? There must be a lot of people.
Good question. So I know you've seen my articles, which is why we connected. This is a healthcare crisis. Where do they go? I don't have an answer right now. So my practice is open and they are starting to trickle in here, but people are a little bit uncertain about the direct primary care model.
Right.
Some folks have insurance and say, I want to be able to find an insurance-based doctor, or some people don't have insurance. I've actually picked up several uninsured patients, such as small business owners who are like, look, I have an income, but I can't afford $2,000 or $3,000 a month for a healthcare premium, but this is a great affordable option. So I picked up a lot of people that way. But the short answer is there's not a lot of care options here. Many of the patients that join my practice today have been out of primary care for more than a year and a half. They haven't been able to find a replacement or they're traveling further for their care. So it's a real crisis here and we're not talking about it. So thank you for highlighting it.
And so I want to dig a little bit deeper into this. Does Medicaid in Georgia pay as poorly as it does in Virginia? you're about 60% of Medicare. So you really can't have a business like that.
Yeah.
Exactly. It's paid very poorly. Georgia is one of the states that also didn't do Medicaid expansion. So I've thought about Medicaid expansion. I do think it's a short-term fix, but with such a poor reimbursement rate, getting more people on Medicaid doesn't really solve the problem for what you just mentioned. If it reimburses so poorly, then it's not really helpful to take it. Also, here, the
so your experience, it's very sad, but one that we hear a lot. And that it annoys me because there's a well-organized movement to expand Medicaid without fixing payments. And they say that you will get people that look like the people in the community to go out to these communities that are underserved.
Right.
But that doesn't happen when Medicaid pays so poorly that doesn't matter the color of your skin, you can't hold the business.
Exactly.
And the hospitals are as cutthroat as you will get. Did they close a pediatric unit and a birthing unit and basically let go of all the family practice of pediatricians in the area?
Yeah.
And are they by any chance protected by not paying taxes as a not-for-profit organization that don't contribute to their own community because they don't pay property taxes like you and I do on our homes? Right. Or like I do on my car. This is a wake-up call. This is a dangerous path. But sorry for that experience. But it seems like you're in a better place right now.
Yeah.
Much better place. But you've highlighted all the things. That's exactly what happened to my system. The two hospitals that closed did have maternity wards. We had labor and delivery, which are now gone. Two less deliver care. If you know anything about Georgia, we're one of the worst in the country in terms of maternal fetal health. The rate of, especially Black women dying in pregnancy or having pregnancy-related morbidity and mortality rivals that of underdeveloped countries. When my friends get pregnant here, I'm truly afraid for them. I want to be happy for them, but I'm really terrified because I know that there's not a great place to get care, or if there is a great place to get care, it's overburdened because of the lack of other resources that are available or that are.
You know what's interesting? I am sure the systems did not close because of lack of patients.
That part.
If you see a patient, you send a bill, you get paid, you're good. But if you send a bill and the reimbursement is poor, and that's what happened in pediatric medicine. Yeah. They got everybody on Medicaid, which was a good idea to get the children Medicaid so they don't wander around without any insurance. But somebody needs to bump up the reimbursement. New York, fortunately, is going up and up. Yeah. But still, they're still bureaucratic and lots of administrative headaches. But let's get back to the original topic. Retail-based healthcare clinics. Was that a good idea or was that a bad idea?
I think the answer is always somewhere in the middle. I like the idea of having more options in the market. And so I think retail-based clinics could have served a purpose. And I'm by no means an expert here. Talk more about DPC and outpatient side, but I think retail has been helpful for some of those short things. I think some of those urgent care issues after hours, you got a sore throat, something that needs a quick checkup. I think it's useful for that, and the convenience of it is great. Pharmacy is right there. If you get the UTI, you pick up your meds, you walk out the door. Where I think it went wrong is that it tried to deliver primary care. And I don't think that primary care in that setting works well. Number one, because of the benefit of primary care, the beauty of primary care is really the continuity of care. And when we have these structures that aren't private, I feel like there's no investment from the clinicians to want to stick around. I say now doctors are almost like NBA players or NFL players. We'll go to the highest paying team, right? But we don't always stay in our communities because if we get a better contract, we're gone. So all those people who relied on us for care are just gone. So that's not true just for retail clinics, but even for these large healthcare organizations. Whereas you and I know with private practice, like that's your baby. You're invested. You're going to stick it out. You're there for your patients for the long haul. You're not just going to pick up and leave because it got inconvenient. You figure out a way to make it work. So I think for long-term relationships, private practice works better. The second place I feel like I failed is for the reason I referenced earlier. Primary care needs a B2B. They closed all of our clinics because we didn't have a hospital to feed. They said that we were really a referral center. So we were looked at as a operational loss. Like we'll take a loss on primary care or break even on primary care so that we can get the referrals into our system. If you're CVS, Walgreens, or Walmart, who are you referring to? They're not going to keep the referrals to the surgeons. They're not going to get the benefit of patients going for mammograms or other imaging studies because it's only primary care. So they realized very quickly that reimbursement does not honor primary care. And Walmart made that they said there is no path to profitability and we are shutting down effective immediately.
Yeah, but I think what their idea was to basically have the customer come in, take care of the sore throat of little Johnny, then maybe walk down the hall, pick up some hairspray, some deodorant, then fill the prescription for amoxicillin. And while I'm at it, let me get some milk also. I think that was the original model.
I think each model is very different, right? In retail clinics. So I think that if you start with a Walmart model, they have a lot of stores in rural America that have no access to primary care.
Right.
And in their mind was, okay, people are already driving an hour, because that's what happens in rural America. There's not a Walmart in every little town in Appalachia. People drive an hour to a super Walmart and they have everything. And they're already driving for an hour. They might just want to get their, kids' vaccines while they're here and, go back to town. Makes sense. But as you said, scaling primary care is incredibly difficult. And I've always said, you cannot do the Walmart model in medicine because medicine is hyper local. And so you need a building, you need an examiner or a van where to examine the patient. And you cannot outsource that to China, Vietnam, Costa Rica, Colombia. You can't. You got to have the van or the office in the town and pay town rates for that rental property. When you hire somebody to help you in your van or in your office, you got to pay them enough money that they can live in the U.S. Right. It's not like I wanted to outsource my Apple phones to be made in China and they cost $300 and I sell them for $1,000. That's not possible in medicine because you have to be where the patient is and they can't fly to China for their sore throat. So Walmart was that model, right?
Right.
Walgreens was what I call catching up. Yeah. So Walgreens saw that CVS had the minute clinics and was expanding. And they didn't want to get left behind, so they bought Village MD and another primary care company. And their model was to put the primary care company on top of their building because people are already coming to the same place. They'll pick up the prescriptions. Again, what they didn't realize is this is a very difficult beast. And yeah, maybe people will come to the doctor, but they'll still go to their grocery store to get their prescriptions filled, or they'll go to CVS or wherever, right? And so now the other thing Walgreens was chasing after was they were chasing after Medicare Advantage because that is very profitable. Right. So if you have a good upside risk contract with Medicare Advantage, you can be getting paid $7,000 or $8,000 for Medicare only to take care of them, everything together. And if you can reduce the cost of care on the 80-year-old diabetic with heart congestion, there's a lot of money to be made there. Yeah. But they couldn't make it. They can't make it. They're divesting of that too. And then there was the Aetna CVS, which is a very interesting story. So Aetna used to be...
Let's get back to that at the end of the podcast.
Let me finish. So Aetna used to be a very good insurance company with Mark was CEO of it. But they realized they couldn't compete with the larger ones like United Healthcare. So their model was to create a partnership of insurance and healthcare hubs where, as you were saying, CVS was going to do the mammograms, was going to do the hearing aids, was going to do the primary care, and it was all going to be integrated. And then the plus side of that was they are going to be able to get, as George said, as people walk by, they're going to buy the bottle of wine that's twice as much as everywhere else, and it stinks because it's there, it's convenient, and you've had a heck of a day with a kid with 103 fever. You need to make a good dinner and a glass of wine. And that program is failing for Aetna Care. So those were the three models, right? And then a bunch of urgent cares everywhere.
I think all of these models are based upon immediate gratification, service efficiency. But Doc, what do you think about service efficiency versus care quality? There's no relationship, as you said, longitudinal relationship with those people. Those people are docking the boxes. They're there for a shift. They leave. They move to another one. They don't know who Dr. Cook is.
That's really where care fails. And if you ask any physician, we're usually, not going to say always, but usually happy to cover for our colleagues, but we know how hard it can be a patient that you don't know.
Yeah.
You have a patient that you've been seeing for years, them a simple or even a complex problem can be made so much simple because you already have that history. You know them so well. But when you're in a model where every time, like you're seeing a different patient, you can't deliver the best care because you just don't know that patient. And that's really what this relies on. One of the things that a lot of us get to hear when a patient comes in and say, oh, my information's in the chart. The chart is God knows how long. It's like asking somebody like to look for a small piece of information in an encyclopedia. Like it's hard to find that information up front. And that's where knowing your physician, knowing your doctor makes all the difference. And that's just where they can't.
It's relationships. And we keep talking about that, relationships with the patients, the longitudinal care, continuity of care. You would not believe how many people go to different various urgent cares around 2 or 3 visits. I went there. They told me I had a virus. I went back. They did a test. They told me I had another virus. They come the 3rd time and I'm coming to you to fix me. And the kid's getting worse and worse. I said, did you tell them that you have asthma?
Right.
Oh, that was important.
Right.
I just looked in the chart and he was in. Did you tell me you're on albuterol? Did you tell me you got a lot of steroids in the past?
Right.
That's very interesting.
And I want to stick to that point because I think where the viral infection, that's a beautiful way to talk about what goes wrong with these retail clinics. You and I treat this all the time. Viruses are going to be here and most cases don't need antibiotics, right? But patients come in, they pay their copay, they see that doc in the box, they're like, I'm sick, I need an antibiotic. And a lot of times they don't. But when they pay their money, there's this pressure to want to give them what they want, the instant gratification. So I get that in my practice too. Okay, Dr. Cook, I'm the sickest I've ever been. I tested positive for COVID. It's time for my antibiotic. If you have COVID, I know you don't need antibiotic. We know it's a virus. You're going to feel horrible. Let's talk about the supportive things you can do. But I said, there are some people that get worse. There are some people who are developing a bacterial infection. If that happens, call me back and we'll take care of it. And in a direct primary care model, that's part of their membership fee. They're not paying an additional copay to come back. Whereas if the doc in the box, they're going to have to pay to come back. So you better fix it the first time. So it disincentivizes not what you mentioned about quality care is let's take the more conservative approach when it's appropriate, not over-treat you because that's inappropriate to do. And if things get worse, you're not fearful of coming back because of a loss of finances to be able to access that doctor.
I think the retail clinics, urgent cares and so forth, they don't have the luxury of telling them, I don't know exactly what you have yet. I don't think it's too serious, but I'd like you to come back and follow up in 2 days and we'll see what happens. Because I always say in pediatric medicine, problems don't go away. Yeah.
No, a great way to put it. And a lot of people, like those URIs, you're going to feel horrible, but then 5 days later, you're going to feel so much better. And if that's true, then great. And we're done. And if you're feeling worse, then we need to readdress that. But patients get very upset. Like, I was here only 5 days ago. Why didn't you treat me more aggressively there? And that's the wrong answer for medicine. Not everyone is pretty aggressively on the front end. And that's what we're seeing happen at these retail clinics.
Now let's compare some models. Let's compare retail-based clinics to traditional private practice insurance clinics to DPC practices in terms of quality and patient satisfaction. So let's go with what you know.
Of course, you always go with the easy questions, right? Yeah. So I'll full disclosure, I never worked in a retail clinic, so I can't really speak to that experience from a clinician standpoint. What is funny, though, is I remember as I was burning out and looking at different models or looking at different options before I started my direct primary care practice, I was getting letters from Village MD. Come here, let's have a better care experience. I was getting letters from Walmart Health. And thank God I didn't follow up on those. I'd be back in the same boat looking for what I'm going to do with my life now. But I will talk about the fee-for-service experience versus the direct primary care experience. Sure. For me, fee-for-service, I'm going to back up because we didn't really talk about what direct primary care is so far at the show. So I think we're coming with direct primary care is a membership-based model of care. So rather than do fee-for-service or pay-per-visit, our patients essentially subscribe to our practice. So they pay a monthly membership fee, which is pretty much all-inclusive of care. Different direct primary cares are set up a little bit differently, where they have a membership fee and maybe there's a small cost per visit or small cost for medications or for labs. So there may be some other costs baked in, but generally to be a member of that practice, it's a flat monthly membership fee. So my patients pay a monthly membership fee, and as many times as they want to come in, as few times. We can do telehealth. They text me. So it's like having your doctor on retainer. When I compare that to my fee-for-service life, remember, I was working for a large healthcare system. And in that system, I feel like the biggest difference when you're in fee-for-service versus direct primary care, you are most profitable when your schedule is, you need all appointments booked, you need everything booked up, because if patients no-show or if someone doesn't come in, that's a loss of income that day. Versus in direct primary care, they pretty much prepay their care. So it's almost like true value-based care. So my most profitable day is when I have a full panel of patients in an empty office because nobody's here, but they've already paid their membership. But that allows me the flexibility to have more availability in my practice. Before, you're incentivized to book up your whole day because you need to get the revenue. Whereas here, I don't necessarily need to book up my whole day, and I can be much more flexible about the way I deliver care. So let's go back to that URI example. And somebody gets a viral infection, and I have my fee-for-service model. That 2-day follow-up is it's impossible. Or at least that's the way I felt, because I was overbooked and double booked, and my schedule was booked to the brim. When somebody needed to come back, to get them in quickly was so challenging. And oftentimes we would squeeze them in, but to me, one of the trigger words I have when I think about my fee-for-service life is, oh, can you work in this patient? Can you work in this patient? Working in a patient means that I am at my maximum. I really have no room for you, and I'm squeezing you into an already packed schedule. So now I'm at 110%, 120%, whatever that may mean. And you're not going to get the best of me because I'm taxed. I'm at my max, and I can't think about this. If you're coming back, like you said, problems don't go away. And if you have a real problem, I need to be fresh. I need to be clear. I need to really think this through. What did you miss that first time that you're back? That's the person that actually needs a lot more attention because there could be something hidden there that I missed the first time. But when I'm working you in, that means I'm already expended. Like I don't really have that mental capacity to really dial into the patient the way I need to. Whereas in my direct primary care life, I see maybe a busy day is about 6 or 7 patients. That's a busy day. Usually I'm seeing 4 to 5 patients, but I'm touching patients multiple times. So I'm sending them text messages. We're responding to portal messages. I might hop on a quick virtual call. So my in-office visits are minimal, but my touch points are very high. So when that patient comes back because things didn't get better, they're not feeling well, I'm dialed in. There's nobody else that's waiting for me. I'm not like waiting to get into exam room 3 next because they've been waiting for an hour. Like I'm there with that patient. So that was a convoluted way of saying it, but I hope it demonstrates the weight of the pressures that I have when I was in a fee-for-service environment versus being in a direct primary care environment.
Now, do you think it's the fee-for-service that's the problem, the patient that's the problem, the efficiency of the practice that's the problem? I'm not sure.
Yeah, I'm not sure either. I think it's a little bit, a little bit, some of everything. I think we have to change the way that we deliver care, what doctors get for care, what patients expect for care. I'm glad that you said that because I did a talk last year at the Georgia Academy of Family Physicians talking about direct primary care and the failure of the fee-for-service system. And one of the docs approached me after the talk and he was like, I don't think it's fee-for-service that's the problem. I think it's more the insurance-based care that has all these misaligned incentives. He's like, offering a service and getting payment for that is not wrong or evil in and of itself. That's the way that business works. So giving a fee for a service isn't only the issue, it's the other structures that back that up, that say a visit is only complex and you document these different things, or if you spend this much time and all that stuff that just, in an insurance-based world, that leads to this misaligned incentive.
Right.
So,
But I think all that stems from when the CPT-2, whatever it came out in 1997, because what happens to physicians? They had to write progress notes by hand. You would not write them. Simple as that. So I don't want to defend the insurance companies, but in their defense, you didn't write anything, doc, yet you billed us a whole lot of money for what you didn't write. So why should we pay you? So you have to justify it. But now with the EHRs and they changed the billing structures with the medical complexity and laboratory interpretations and whatever else you do, continuity of care, it's easier to justify a higher level of care.
right.
I think. I'm not so sure. That's why sometimes I wonder, everybody blames the fee for service, but I think there's a little bit of inefficiency, workflow, physician habits, physician OCD stuff, that all of it mixed up messes things up.
I'm glad you said that because when I was, again, still in fee for service, and again, that issue of having to have this full schedule, that a wing was having a full schedule, and the full schedules with what we needed to break even or what we needed to make the income that we wanted. To me, it was just unsustainable. I know in peds, I see a lot of patients, and the primary care from adult patients that are very complex. More than 20 is just too many.
Now, for adult medicine, I think every person in adult medicine that's over 65 is probably a level 5. They got 15 medications, 30 different problems on a problem list. But the truth of the matter is, nobody would write that down in the past. I remember when I first went into private practice, we were on paper. I was always trained. You should ask your allergies. You should ask what medicines you're on, your problems. The senior physicians would say, oh, you don't need to do that because it's already written in the chart.
Yeah.
But it should be part of the progress note each and every time.
Exactly. But you're right. Those patients are much more complex. We're expected to see more than 20 a day.
That's a lot. That's a lot for adult. That's a whole lot for adult medicine. If they're 30 years old, 40 years old, yeah, they're probably okay.
And to your point, like I remember trying to get myself to adapt to the system. And I took this course, which was a great course about learning how to chart better, chart faster, close your charts as you go. And it helped me a lot, but I felt like it helped me take more abuse, if that makes sense. Like I got more efficient and I was letting go of some of the OCD, and not every little thing has to be documented. Like what is the bare minimum that gets to the point of what the heart of the visit is and it's enough to bill a visit. So I got much better about that. So as my efficiency went up, what happened? They're like, oh, great, doctor, look, there's more capacity in this. And I was like, no, I did this to work it back, not to be able to take on more and more because I already felt like I was beyond my limit. So again, in trying to adapt to the system, I feel like it invited more and more trauma, if you will. So now in my direct primary care light, I am documenting for myself and for that patient, right? I'm not documenting to submit it to insurance. It doesn't really matter. Not to say it doesn't matter what I put in the chart, but it's less important than it ever was. So now I can document just what the essentials are. I've leveled that up that now I'm using AI to help me with my documentation, which has totally changed the game.
I know.
AI plays in the background. It captures the essentials of the conversation, gives me a beautiful note. I maybe make it one or two tidy up for here, and my note is done. I'm not adding like all the ICD codes. I don't have to ask exercise counseling because it's a pediatric well visit and I won't pay for it if I didn't document that thing. Like it doesn't matter what the coding is. So now I feel like I can be in that room. I can dial in with that patient. I don't have to worry about taking comprehensive notes while I'm doing that. I close that chart and I can just be so much more efficient. So that's actually going to allow me to take on more patients in a way that doesn't feel stressful.
Yeah. So we go back to the relationships and the longitudinal care. I'm using the AI also, and Dr. Bravo is using it also. I feel like I'm almost not working.
And it's so much more enjoyable now, right?
Yeah.
I can literally just put it to the side and talk with my patient.
Yeah.
And it's made that it's so much more fulfilling now than it's ever been that I don't have to worry about the documentation. When I think about in the past, my level of documentation, my day would be, I wake up at 5 o'clock in the morning. I would pre-chart for as many of my patients as possible because I have to get that in my head. Because once I get in the room, I got 8 to 10 minutes to really get the job done. So I have to come in as prepared as possible. I would pre-chart for hours before I got to the office, collect the information and have to chart as much as I could. And then after work, go back and keep charting, right? And then answer the portal messages and do the medication refills and do the lab results. It just never stopped. So every day was like a 16, 18-hour day.
Well, that's a lot.
Yeah, and it was business as usual. It was just like, that was not a bad day. That was every day. So I would say I didn't know if my day was going to be bad or worse, but those were the two options. It's either going to be a bad day or a worse day because of the amount of work that we had to do. So now I go in, my AI helps take the notes. So while my nurse is working at the next patient, now in between patients, I can answer that portal message. I can do my refill. The work is done at the end of the day.
Now, it sounds like you did a lot. Okay. Mm-hmm. Do you think it was that there was a lot to do? Do you think it was inefficiency on behalf of the physician? Do you think it was inefficiency on behalf of the clunky system, the EHR that they had, where you had to go through a lot of hoops to complete the same thing? Because it sounds like once you took the computer system out, your life is better.
Right. I do think that the EHR system is incredibly clunky. It's something that's not going away. And there's a lot of benefits to EHR. I love the fact that you can look back more streamlined, that you can search the charts. You can when did they last take amoxicillin? And you type that in, it takes you right to that date. So I don't think we can poo EHR altogether because there's some incredible benefits, but I think we have to define our relationship with it. In the fee for service model, and especially in the employee-based model, it was death by 1,000 clicks. If I didn't click the tag that I didn't reconcile the medications and the whole visit didn't count, and now I'm not going to get paid, regardless of whether I did it or not. So there's a lot of really foolish things that you have to do to justify your payments or to justify your care. And then if you automate those things, sometimes it could be somewhat fraudulent. Did you really do it? Or did you just program the machine to say that you actually did it? So I think it just puts you into a rock into a hard place about using these systems. I do think that there's some physician inefficiency, but I don't think the physicians really can be efficient if you're relying on inefficient systems, if you're dependent on these inefficient systems. So you really do the workflow. I remember one of the worst days for me was when I was in my service life. At one point, I was able to negotiate getting 20-minute appointment. And that was my sweet spot. Like I would never want to do that now, but I had 20 minutes appointment for everybody. And in the system, they said, no, we need to standardize. All of the physicians across the institution need to be on a 15 or 30 schedule. So it's going to be 15 minutes or 30 minutes for new patients and physical. And that loss of 5 minutes really hurt my workflow. Like having that extra 5 minutes per patient made all the difference, but then I was forced into this 15-minute model. And one thing I cannot do is see 4 patients an hour. I cannot see 4 adult patients an hour. And that would happen. Well, it would be like, okay, this is the diabetic, this is the depressed patient, this is the thyroid and hurt my foot follow-up. Like, and that in an hour, 2 back-to-back hours of that, and I'm done. Yeah. I'm done. I still have an hour left of clinic to go. And I'm already behind schedule. So I think a physician can only be as efficient as the models that they're using. And when you have no say over your schedule, no say over your EHR, then I don't think the physician can get more efficient.
I think, to your point, this is another one of my big concerns. So adult diseases are bleeding into not only adolescent, but pediatrics now.
Oh, yeah.
And in pediatrics, there are very few quick appointments anymore.
Oh my gosh, you're absolutely right.
And it doesn't pay to see them. And the other problem we're having is, and this is all because of efficiency and cost containment, we just simply don't get paid enough. We no longer have the luxury of having an RN in the clinics. We have a medical assistant. And some medical assistants, as in anything else, some are great, and some of them don't really understand the importance of a medical record.
Right.
They're oblivious to it. And they don't understand that I can't do all the workup for every patient that comes into the clinic because it would take me an hour per patient.
Right.
So I need to count on extenders who do certain things and do it accurately at least 85% of the time.
Right.
So that I can look through that data quickly and move on to the problem and get the patient in a good track and move on to the next patient.
Absolutely. And I feel like that is another thing that hurt. To your point, Dr. Roger, about efficiency, in those systems, they set the workflow. So I'm a millennial doctor, if you will, but I came in right at the end of paper charting and EHR. So I watched that transition and I watched the burden of documentation and administrative work push towards the physician. So a simple example of that would be something like a referral, right? So I was a med student watching the doctor that I would rotate with. They say, this patient needs a referral. Let's refer them to neurology. They sign the paperwork and their staff would do the rest. Now they can move on to the next patient. But now I'm in a system where we use this big epic EHR and only the doctor can click referral, right? But other members of your team don't even have access to that button. Because that's below, they're not at the security level to be able to do referrals. Only you can make that decision. So now I'm the only one that can do referrals. I'm the only one that can target so many things because of the clearances I have in my EHR, and I can't spread around. So that's another thing that's helped me again with my efficiency here on my direct primary care practice. Now I decide who can do what. So yes, ultimately I have to sign off on it, but I can say this patient needs to be referred and my staff takes care of the rest, or this patient needs whatever it might be, and I can delegate that to my staff so I can truly work at the highest level of my license.
Yeah, and to your point, like yesterday, it was a very frustrating day in clinic because of the way they schedule the patients. They brought in 5 physicals at 30 in the morning.
Oh my gosh.
Okay, and one of the physicals is an 18-month-old, and the mother filled the paper MChat, and she marked that the kid's not playing with toys, doesn't bring toys to her, doesn't point with her fingers. But the medical assistant documented that the MChat was normal in the EMR.
Yeah, but who's responsible? Do you think the medical assistant is trained to understand that?
George, a monkey could be trained to do that. All you're doing is there's a set of questions, yes and no, and then there's a form in the EMR, and you click yes and no. She's just lazy and stubborn and doesn't want to learn. And so she just clicks yes on all, and it populates the fields on ECW.
That's inefficiency once right there.
So it's an efficiency twice, right? But it's also dangerous because I'm giving the wrong information. So I did an ASQ 18 months and the kids got global developmental delay.
Mhm.
So I'm already behind and now I have a problem to deal with. Okay.
But-
And then I said, okay, I need you to go see OT, speech therapy, and early intervention. Write the referral because that's a workflow. So they put it in the CW, the referral, where it's going, but it's documented that we refer the patient.
Mhm.
She didn't put it in the computer. Okay. So that's the kind of problem that if you had somebody that had a 2-year LPN degree that had been trained on the importance of documenting properly because you're dealing with somebody's child.
Yeah, but
You're not dealing with a widget.
But what you're describing is not medical assistant level work. This is doctor work.
Or
MChat looking at it. I think
transcribing it, George. You
no,
don't even
not
do
putting
it.
in the numbers.
You send it on Frisia, and it
Yeah.
comes back and it populates, and you look at it.
Yes, but
Okay.
as I tell the students all the time, I do a formal developmental questionnaire. I ask all the questions and I observe the stuff. Then, if I see something funny, that MChat better agree with me. Okay?
Okay, so this is a person not doing her job. That's
Yeah.
really what it is. But it's a problem because it can make you make the wrong choice.
Right.
Plus, it delays you. Plus, it's a bunch of rework.
Yeah,
And then you
it's a
go-
little bit of rework.
be reimbursed so poorly, it's hard to find and attract the staff.
Right. A good LPN, a good 2-year RN, they were phenomenal, fabulous. You came in there, everything was set up for you. You could trust them when they told you when this kid's sick or this kid doesn't look right, or I don't know what's wrong with this kid, but I don't think the mom answered the MChat correctly. So all of these things, having to be responsible for the care of the patient, trying to be personable,
Mhm.
trying to understand the needs of the parent, then trying to document it on ECW, which I am not a fan of. And then on top of that, having to double check everything the assistants have done because you can't trust them to do it right. You cannot see 3 patients an hour.
I don't know. It's a
And
tough.
so
you have
again,
to
it goes
find
back
a
to what-
balance. You have to find a balance. I don't think medical assistants are trained. I don't think it's in their job description to make medical decisions.
Yeah.
They can't
not
even
a
give
medical-
shots. They can't even get shots. Do you
Oh,
know why in New York they
Virginia-
can't give shots? Do you know why they can't give shots in New York?
The nurses lobby legislature.
Besides that, the reason is they cannot make a medical decision to decide what vaccine to administer. That's why.
Can they not follow a physician order though? So if the physician orders vaccine, can they? They can't. They just can't do the injection like they can't.
They can't do anything. Nurse LPNs, they can follow a physician order. Okay. So if I see a patient, I order a varicella vaccine, the LPN can administer the vaccine that I said because I made the medical decision process. Medical
Got it.
assistants can't even do that. They can do vital signs, they can put patients in, they can plot growth parameters, and the RN, a higher level of training, that's the one that can go look at a medical record and say, hey, you're due for your MMR, and she can administer it.
Got
That's hierarchy.
Right.
I don't think personally a medical assistant can make medical decisions. They can follow, they can execute commands, I think. They can do
Right.
vital signs, but that's it. They train for a year or two, not even.
Yeah.
Anyway, so we
Yeah.
derailed again, Herb. Let's get back to this retail and retail-based clinic. Why do you think all this retail-based clinic stuff happened? Was it just a play on Medicare or value-based medicine? I don't think it existed back then, value-based medicine. But the Medicare Advantage, as Herb said earlier, was probably a factor in it.
I think they saw a business opportunity.
Mhm.
And I think that they did not pay attention to what, especially private practicing hospitals have been saying for a long time about how poor the reimbursement is. There is a track where if you play the game correctly, then you can get rewarded really well, right? So when I was in my healthcare system, we were part of an ACO, and everything we did was basically the Medicare way. Like if we hit this benchmark, if we get so many Medicare physicals, if we cross that threshold, we're going to get this big dumb bonus from Medicare. So really our patient became Medicare. Regardless of what our patients needed, our patient was Medicare. We need to do the physicals. We need to do these many screenings. We need to do. And some of that trickled down to what the patient needs, but many times it did not. It did not. So I'll tell you an example in my office was because we had to do so many Medicare physicals, like I think at one point we set a target of like 85% of our patients need to have their Medicare physical, which is good to do. But then what happened to my schedule? My schedule became full on Medicare physicals, whether the patient wanted it or not. So when my patients were trying to come in because they were feeling bad or there was a new issue, I was crowded out by all these Medicare physicals. Again, I was treating the wrong person. I was treating the wrong patient. So I think the retail space tried to play that game and quickly understood that it is a no-win game. It's really hard to make up Medicare requirements. It's hard to get people to do things that they may or may not want to do. Like some folks just don't want to come for the Medicare physical. Doesn't mean I can't take care of their other issues, but they don't want to sit there and do that questionnaire. They didn't want to, they just didn't want to do it. So it doesn't mean that they can't give them care, but if you don't give the care the way that Medicare wants, then you're not going to get that big bonus that comes down the pipeline.
Yeah. If you have too many patients to be seen, I don't know, in my simple mind, that means bring on another doctor. What's wrong with that? But a hospital system will not bring on another doctor until the first doctor is overwhelmed, overspent, breakdown. And then they bring a new doctor that's younger and theoretically faster and cheaper, but that one's even more inefficient. Can't even half of what that doctor.
But we also see it in pediatrics. There are some practices that pretty much just do well child exams all day.
Yeah.
And very few sick visits. And they're okay with it. They're like, I can't compete with the urgent care that's open 7 days a week from noon till 10 p.m. And people don't have to make an appointment. They don't have to do anything. They just walk in and they give them what they want and they leave. And there's no way I'm going to be able to be open from noon till 10 p.m. It's just not going to happen. And I'm not going to find pediatricians to work Saturdays and Sundays, or nurse practitioners or PAs. And I guess I'll just have to make peace with that and see them on follow-up.
Yeah.
And so that really hasn't helped in some ways.
I sat in on a discussion once at an insurance level meeting where they brought in a whole bunch of independent practices, urgent cares. It was like a brainstorming mastermind thing, right? And I'm sitting next to this guy that had an urgent care and how busy he is. And then I'm also sitting next to some primary care physicians in the community. And then I said to the urgent care director, I said, I don't understand how all these guys are sending all their patients to you guys during the middle of the day when they should be seeing them. He says, Doc, the secret sauce is they're all capitated. So they have to see these patients, but they want to see the well care so they can get their quality incentive program. And they send all the sick visits to us in the urgent care. So we're feeding the beast and everybody's happy. And this was in an insurance forum.
Right. Yeah. And that's exactly what happened. And that drove me insane. So at my office, our system had an urgent care less than a mile away. So I didn't get the game back then, but the game was, yes, we go after the higher ticket. Then there's like the Medicare physicals and the new patient appointments. Then when that's damn with them, they can go to urgent care no matter, what was going on. I got so tired of sending my patients to urgent care. So it felt like a no-win situation in that my patient will call the same day. I'm already booked at 100%. Dr. Cook, can you work this patient in? So there's my dirty word. And sometimes I would try to work them in and I would feel totally exhausted, or you can send them to urgent care. So I was sending people to urgent care, but then they go to urgent care, and when they finish doing whatever they do there, what's the next statement? Follow up with your primary care. So they try to follow up 3 days later, and still my availability is shot. Like I wasn't available for 2, 3, 4 months out. My same day appointments, my staff started overriding the schedule. I'm like, we need to get this person. So my same days were all gone. And when I watched the game from this perspective of seeing what was happening, we didn't really care about what the patient needed. We cared about what was going to pay them up. And I think that's how that happened. For me as a primary care doctor, it feels horrible to look my patient in the eye and say, I'm going to be your physician, but when you need me most, I'm not here. I'm going to send you to urgent care. And this is in this direct primary care model, I no longer have to do that. When they come in and they're sick, I see sick care again. I actually have to brush up on my sick care still, but I wasn't even seeing that time. So when it's the strep protocol, but they never even made it to me because if it was a sore throat, the staff protocol was shipped them to urgent care. That's a low-level visit. They don't need to come here. We need to pack our schedule with these Medicare physical patients.
Yeah. All right, Dr. Bravo, the last question. This is your baby. Why don't you take it away?
Last question. I think this is the really sad part of the story, right? We take Aetna as an example. Aetna was an early adopter of the nurse practitioner model in the retail clinic. I don't think they made money at it, but they weren't losing money at it. Then they tried to expand the model to make it a healthcare hub, which to me didn't make any sense because I don't know, this is just me, but as a consumer, I feel CVS is low quality and very expensive. I think of the CVS when I'm at the beach, and that's the only place I can go get a pair of flip-flops because I forgot mine. And they're not the nice flip-flops, but they cost a lot of money, right? And it's cluttered and everything is packed. I rather not shop at CVS. And I'm like, if I feel like that about a pair of flip-flops, why on God's earth would I go to the doctor at CVS? That was my first question when they did that. Then when they made some investments in clinics and then went very aggressively after Medicare Advantage, they lost their shirt. So they've lost $2 billion in their last report. And they fired the CEO of that division. And what do they do? What do insurance companies do? The CEOs, CFOs, the C-suite, they don't take pay cuts.
Never.
Their bonuses don't decrease. Their stock options don't decrease. What is it that they do? They turn around and they tell the people that have to buy health insurance, our loss ratio was 95% last quarter. We were supposed to be at 85%, so I have 10% admit cost and 5% margin. Therefore, I need to raise your healthcare premiums for your company by 15% this year because of the mistake I made going into the wrong market and not knowing how to manage it. That's how they solve the problem. And then the second thing they do is they go look for the independent practices, the ones that are in the community, the ones that are not affiliated with a mega not-for-profit health system that breaks their arm when they come to the negotiation table and say, oh, we're going to bundle G2211. It's a good code, but it's part of what you're already getting paid for the sick visit. And we're going to bundle this, and we're not going to pay for a screening test. And you have to do it because it's part of your quality, your QIP. And it's the right thing to do, but we're not going to pay for you to do it. And by the way, we know we haven't raised your fee schedule in a couple of years, but we can't afford to raise your fee schedule right now. But I'm below Medicaid in my state with what you're paying me. Yeah, we know it's terrible, but right now we can't afford to raise your rates. If that's not good enough for you, we understand you'll have to leave, but we're okay with that too. That's how the health insurance plans work when they lose money for silly decisions. And we are, as you had said at the beginning of the episode, we are at a healthcare crisis, primary care. I'm tired. I don't mean to be offensive, but I'm tired of hearing about, what is it now? Freedom DEI or DEI or IED or people. Everybody needs care. Everybody needs access in every community. And you're never going to attract people of any color, any background, any lived experience to go to a place where you can't make money after they spent 11 years of their life training and they have $300,000 in student debt to pay off. So the problem is payment.
Yeah.
Pay people to do the work that they're doing in every community fairly, and people will gravitate because people that go into medicine are good people. They want to help other people. The orthopedic surgeon, yeah, he wants to make money, but he loves taking away pain. He loves it when he replaces a knee and that 50-year-old can now start walking again and holding his grandchildren. I love it when I have a kid and they have a BMI of 38 or 39 and they weigh 217 pounds and they're down to 195 pounds in 4 months.
Right.
I love it. Right? That's why we went into medicine. But if you want people to go into the communities, every community, pay them.
Yeah.
And you won't have a problem.
I think what direct primary care does is it puts it back on us to set our payment rates. Right now, we're so dependent on insurance, it means, again, we have to play by their rules no matter if they make it or not. And so direct primary care, the radical approach is they work like any other business. If this is the service I provide, this is the price for it. And as you can see, the market, there are going to be some places that operate more like a CVS, like we're going to be a little bit more, or we're going to be a little bit cheaper option if you want to. You have some places that want to give more concierge level care. You're going to have places in the middle, and then the consumer can shop for that. But what needs to happen on top of that is we need to change this insurance paradigm to make it truly insurance where it covers the catastrophic and the unusual and not every. And that's why I'm in direct primary care, because I think that we've asked them to pay us more and more. And what happens is premiums go up and we don't see that, right? Like it goes to the wrong place. So the answer right now is more money, but redistributing that money. So let's make these premiums smaller. Let's make insurance more affordable and only use it where we really need to use it, when you need that knee replacement or you need to get hospitalized. When it comes to your primary care, the care that really could be very inexpensive, we decouple that and we make it affordable. So I think I'm done asking insurance companies to pay me. I set my rate.
Yeah.
And I let the market.
Yeah, that's very nice, very good, very interesting. Like I said, when we spoke earlier, I did catch tail end of when they were paying with chickens and eggs, but the fees were very inexpensive. Like I said, they used to start with $25 visits. Now they're $200 visits. And what do you do with?
Well, here's the thing. It's expensive, right? And I don't share if you're willing to. I want to share mine. I'll tell you, I'm on a very affordable plan through the ACA, and I paid $400 a month to cover myself. That's a lot of money, right? $400 a month, whether I did a visit or not, just to make sure I have that covered.
I can beat that. We pay $4,000.
$4,000, right? So imagine pay even just $1,000 for catastrophic coverage. So if I need my knee replacement, if I need my hospitalization, and then the other $3,000 I can divert. A $200 visit, if you're already paying $3,000 extra a month for coverage that you may or may not use, is nothing. So if you can reallocate that money toward your direct care or toward your maintenance care, then it makes sense. But we're just spending the wrong way.
You're correct on that. And
it doesn't work.
I think it's by design. They want to do that because maybe people that are younger, they don't go to the doctor. They still spend the money, or the hospital spends the money for them, or the practice spends the money for them, and they keep rolling and rolling. And the sad part about it is the company that we use doesn't even embarrass at how much they pay the physicians. It's embarrassing to me how much they pay the physicians. Yet we're
paying money already. It's not going to care anymore. And so that's where direct primary care is. Let's stop eating the beef. Like we're done doing that. And it's hard because right now it's hard not to do both. We don't really have a lot of catastrophic options just based on the way insurance is structured right now. Some people are finding loopholes in that through health share. So there's companies out there where it's not necessarily insurance compliant, but you can get an insurance like product that will protect you if you have a high cost event, but then you pay separately for your primary care. And almost always you're going to save money. So in the end, you can get this incredible cost savings, and you could splurge on your primary care doctor and spend $300 a visit if you're no longer paying $4,000 a month for your insurance. So I just think we have to change the way that we're paying for care and cut a lot of those folks out of the equation. Like we said, those CEOs that don't take a pay cut, but keep increasing premiums. But for some reason, with these increased premiums, this will add to Medicare Advantage, where physicians are going to take a 2.9 cut next year.
Yeah, and they're increasing the practice's payment by 10% this year. And when you negotiate with them, they want to give you an increase of 1%. So many levels are wrong.
But there's also a problem there, and I think you alluded to it, which is very important, is we need to invest more, and family practice is a little different than pediatrics. We need to invest more in primary care, early detection, prevention in the young. If you can prevent, if you have a well-managed asthmatic and they're not going to the hospital, that's big saving. If you can get teenagers to come into adulthood with a BMI of 25 and not 33 or 34, that's going to be less spend on joint replacements. If you can keep that young person from being overweight and becoming a diabetic, that's a huge saving long-term on the system. But you're talking about decades and decades. And to do prevention, it costs money.
Prevention, because what people look at is what you spend, what you say. It's hard to.
You can't tell what you say, because how do you know,
down the
how do
road.
you know that child was going to be a diabetic and going to end up in dialysis when they were 50, when he's 16, and he's a pre-diabetic? You don't. But
if you know what happens, we don't invest in prevention.
Yeah.
And so until we spend more, invest more, it's going to be a tough walk. We're going to have to spend more up front.
Or we have to spend differently.
You have to spend more initially to provide the preventive care that you're going to see the payout 30 years down the road. And so that's going to save money. And at the same time, in the most expensive population, you're going to have to find ways of providing quality without it being so expensive. Right. And that gets very touchy, because that's where the hospital makes all its money.
And I agree, but I still disagree. I don't think we need to spend more than we need to spend differently. The hard part is that's taking money out of some people's pockets who are going to be very reluctant to give that up. Right? Yep. Do we need those managing care? Do we need $4,000 insurance policies? I'm sure you got more than $20,000 worth of care last year, but that's what you spent more than that just to keep your health care. So we're all spending the money. We're just spending it so inefficiently.
Correct.
So we change the way we're spending that money. We take the money away from the health insurance and put it back into these private practices, put it back into the hands of consumers. We're going to see better outcomes. But I think when we lead the conversation of we need to spend more, and we're already toppling our economy with our cost of healthcare, that conversation's not going to go very far. I don't think we need to spend more. I actually think we can spend less. There's some people that don't need to be making money in healthcare right
now. Yeah. Well, that's a tough podcast in itself, Herb.
Right. That is, but that's very interesting. Yeah. And I do love the DPC model in the sense that you're not nickeling and diming people. Yeah. Right. You're like, here's what it's going to cost for me to take care for you for a year. Like your accountant. Your tax return is going to cost $3,000, and I'm going to file this and that and blah, 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 blah. And just call me when you need something. But that's $3,000.
Exactly.
And I'm not going to do anything but that, and we're good. And so people can budget that in, and it's not that expensive. It's many times less than what you pay for your cell phone at Verizon.
Exactly. I remember, even though I'm considered one of the more expensive offices, I'm not $3,000 free. But yes, you invest in your financial health, but our physical health and our mental, emotional wellness is so much more important. If we're not well, who cares how much money we have?
That's right.
So it's crazy that you'll pay your accountant $3,000, but we him and haw about paying our primary care doctor $3,000 to get unlimited. I just think we have to change that paradigm. And once we start thinking framework, it makes more sense, and we're going to save a lot of money, not necessarily have to spend more money.
Let's see what happens. I'd like to thank you, Dr. Cook. This was a spectacular. We have to cut Herb off because he won't stop talking about this stuff.
Well, so much, but I really appreciate
we'll have to invite you back where we can talk about, should we spend more or should we spend less? All right.
Let me tell you this before we sign out. I was working on a slide deck for another project, and I'm a very simple man. So I just drink black coffee, no sugar. Better if I can make it at home. But sometimes I have to buy it at Starbucks or the grocery store because I'm going somewhere.
Yeah.
And I looked up what a caramel macchiato costs at Starbucks. It's almost $7. Yeah. And there's people that get one every day.
They do.
Right? So that's $210 in coffee and sugar. But they won't pay $80 a month to have a doctor that has time to spend with them.
Yeah, welcome to reality. Thank you, Dr. Bravo.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.